Good morning, Dr. Julie Andrini. Welcome to the podcast. Um,
Good
I've been looking
morning.
forward to this for ages because you have an amazing background. I'm very curious what your background is, how you found your way to the Methodist, which is a very complicated organization. And I asked your assistant, what is your title? And you have four or five titles. So tell me more about who you are, how you got here, and what your first week on the job was. What was that
Okay.
like?
I started my background actually as an economics major in business in New York City.
Oh,
And I was always interested and even did my economic thesis on overutilization of diagnostic testing, comparing Cornell with Lenox Hill Hospital in New York City.
sure.
Went to medical school at 31 and went into academics. Went on to become a program director of a residency program, a director of general internal medicine, and a vice chair of medicine, and then moved into population health because I've always had an interest in finding opportunities to take care of vulnerable populations by engaging physicians. And at Houston Methodist, they were starting a population health department. They were interested in this. It was a really good match for me to transition and to build something from scratch because fundamentally, I'm a builder, an architect. I like to do things that haven't been done before. And so this was a really good match and a great opportunity for me at Houston Methodist, which coincided with them building a primary care network, which is the
Sure.
foundation of population health. So at here, I'm the Senior Vice President for Population Health and Primary Care. I'm a general internist, and I work in the Department of Medicine as the Vice Chair of Mentoring and Development. So I work with a lot of learners because that's another key passion of mine is mentoring and educating others.
Okay, so all your many titles, what title are you going by today as far as the MSSP program, the Medicare Shared Savings
Okay.
Program?
So the Medicare Shared Savings Program, I'm the president and the CEO of the Houston Methodist Coordinated Care Accountable Care Organization. It is a Medicare shared savings program, and all Medicare shared savings programs are accountable care organizations.
All right, let me back into the fundamental question. If you do it right, what kind of rate of return can you at least envision, aspire to in working with CMS?
Well, we had our best year ever in 2024, which is the most recent data released at the end of 2025. We had an 8.75% savings rate in
Uh,
taking care of almost 50,000 patients. The average savings rate for other ACOs nationally, there are 476 ACOs nationally like ourselves, and the average national savings rate is 4.7%. So it is doable. We just happen to have 8.75%. We've been doing this since 2017, and we have a continual mindset of improvement. So that's what we've been trying to do each year.
Okay, it didn't just happen. Let's get into it. One of the things you're absolutely passionate about is, physician buy-in and leadership. And, knowing something about the organization, it's a unique culture. And what it suggests to me, at least, that the intervention and the coordination, the collaboration, it's not going to just happen without significant culture change. So, what do you do about physician leadership and support for this kind of a very challenging program? How did you go about the physician leadership piece?
Thank you. I really appreciate that question because you're absolutely right. It is a cultural shift. And so, one of the key factors that I think was most helpful was me, myself, having these decades experience as a general internist and being in primary care because I was one of them in many ways. And so there has to be a level of trust and buy-in to do any of these programs because they are required to lead clinical transformation to make this successful. And so you have to engage them. So how do we do that? We did several things. One, I go to all the practice meetings, meet all the physicians, know them, recruit them myself personally. And then we have a structure where our board for our accountable care organization is made up of the primary care physicians that are taking care of these patients. So we have our own board. We also have a physician advisory council that are these same physicians. We have a quality committee that's made up of these physicians, and we have a finance and operation committee. So we engage them in decision making and engage them. They're smart people, have great ideas. These are their patients. But most importantly, two other factors are key. Actually, three. One is transparent data so they can see how they're doing on their quality metrics, how their practice is doing, and rewarding them for their efforts. And we do that by aligning the dollars we earn from Medicare to financial incentives to the primary care physicians so that all the hard work they put in to make room to see patients when they're discharged from the hospital, to get to the 90th percentile in quality, is supported by alignment of financial incentives to these goals that are very transparent and supported by data so they know how they're doing every month. That's really key. The other thing is we
Wait, wait,
provide
wait,
them with,
hold on just a
yes,
second. Are you saying that I understand what you're trying to do? Are you saying that you personally go to every physician every month with all these data sets?
I don't go, I have a team now.
Right.
When I started in 2017, it was me. But now we have grown to over 355 physicians and APPs in over 90 locations. So we now have a team, a population health advisor team that goes every month to their practice meetings. And I every month prepare with my team the presentation and the data that we're sharing with them.
All right. So when the team spans out across greater metropolitan area, how many physicians are you talking about? How many team members does it take to basically meet with, educate, incentivize? How many, what's the staff complement it takes to be that
We
successful?
have only four population health advisors and one director over them because this is a full-time job, actually.
And how many physicians?
And in terms of number of physicians, we have over 355 in 90 locations
All right. And this is every month.
every month, except for usually one summer month and one winter month. So it's usually, and also what we morphed into, the largest practice sizes now have more meetings, and the smaller practice sizes with the least attributed have less. So minimum of 6 meetings a year now.
Now, you've mentioned that physicians are by nature competitive.
Yes.
And maybe Methodist physicians are even more competitive. Um, when your team meets with them and you present the data for the last month, what do you show them? How do they react? How do they digest this? And how do you do it in a way that incentivizes them to be even better? Physicians have a lot of pride. They're
Mhm.
very competitive. How do you work with those innate drives? How do you
Mhm.
present the data? How do they react to it?
So in 2017, I'm going to start there. We made the decision to show data unblinded, transparent at a
Mhm.
practice meeting. And that's when I was going to the practice meetings because I had to see that reaction where every physician in the practice sees how every other physician is doing on every quality metric. And
By,
I
by,
knew
by, by name?
by name. We made that decision at the very beginning, and that was very effective. And I did go to those practice personally where I thought this may be an issue because I know these physicians. And so
Right,
I
right.
went to those, and yes, then it became the data isn't right. That was the beginning, 2017. So then I said, okay, let's sit down and look at it and find the errors. And then when they didn't find the errors, they trusted the data. And once they trusted the data, they realize, wow, because if you're not measuring and sharing data, everyone thinks they're the best. Everyone does
Yeah.
until you see exactly your performance and you trust the data. So that's how we began. And then now future state is we've created an ACO honor roll for the best of the best in the large practices,
Oh,
the
this was great.
small, the medium, and everyone wants that. And we give them trophies and we celebrate the whole practice with a lunch and we give out awards. And it's very competitive. And those are aligned to the financial incentive.
All right, so everybody knows what strata that they're in.
Yes.
Well, there's a plus and a minus to that for sure. Okay, so you show them the data. They understand, okay, I can achieve better performance, better outcomes. What's the financial incentive? Is the financial incentive the main thing? Is it pride? Is it professional responsibility, ethics? What drives the increment of improvement?
I think it's a combination of many ingredients, but when I speak with these physicians, and certainly the role of this is putting patients first, quality first. That is the most important component of the program, improving quality of care for a population. And I think they take great pride in that, and also in knowing they have a multidisciplinary team that works for the ACO supporting this. Social workers, pharmacists, nurses that they can refer to. It's not like they're all alone. They're getting all of this support. And I also think they take great pride in being the #1 ACO in academic medical centers in the nation. They take great pride, as I do, in that. I mean, it's a complete collaboration. Certainly, I think financial incentives help, but professional pride, medical ethics, caring about patients first, and improving care for their patients with support and with a voice at these committees, I think all that adds up.
So go back to your meeting with Dr. Jones, and she's not in the quadrant she'd like to be in. What's the financial incentive part? I mean, how
Oh, okay.
palatable is that?
Okay. So if you're in the 90th percentile for quality, you would be paid a certain amount of money per patient. If you're at the 80th, that would be lower per patient. If you're at the 70th, that would be lower per patient for the patients attributed to you by CMS,
Okay.
right? And below that, we may not give any incentive at all because
So,
we want to be the best.
okay, so what, how much more does the best get than second best or third best? You're talking minimal percent of PMPM. What's the increment here?
Oh, okay. It's significant. So on average, in our ACO, the average is about $50,000 per PCP per year in incentive. The average, with some people more than doubling that based on number of patients and their performance. So it's really, and we give them, it's in their hands to achieve this. These are their patients. These are achievable metrics because they see their colleagues who are achieving it.
Well, is this a contract negotiation where you're going to promise 100,000 if you do X and 120,000 if you do Y, and they understand what the increments are?
Mhm. We bring every year to the board, the ACO board, what the incentive is going to be for that year. It's always first based on number of patients that CMS has attributed to you and quality scores. And then we've added in other things that we want to achieve, like follow up post discharge. Did you
Right.
follow up with 75 or 80% of your patients? Did you see 90% of your patients this year at least once? We've added in other incentives with our board discussing this, and we even model it out to see how do we do last year? What would that mean for the next year?
So is there always going to be a higher quadrant and a lower quadrant? Somebody's always going to be on the bottom?
That's usually, it's
Everybody
like a
wants
bell
to.
curve. It's almost like
Okay.
a bell curve. It usually is when we design a good incentive, I see it's a bell curve, right? The 90th and the 70th, let's say on the
Okay.
bell curve, and most people are in the 80th.
So for those that are on the downward slope, over time, do they become more incentivized
They
to?
do. They
Okay.
do. Amazingly so. That's exactly what we're seeing. There's less and less each year. It's less of a bell curve because there's less in that lower. That's exactly what's happening.
All right. So you said they trust the data, especially the quality data.
Hmm.
Why do they trust it? What are the components that really speak to them and they think this is real, this is credible, I
Hmm.
get it?
We have created dashboards for all our physicians that they can see in their own electronic health record how they are performing. And so we created that for them. And then we, at those meetings with the population health, review that data. If they find discrepancies, they bring it to our attention and we correct it. or if there isn't a discrepancy there, think there, and our team supports them. They know they have our full support, that we want them to do the best they can do because it only helps the entire ACO.
Okay, so that's a collaboration. How does your team member help them, and
Hmm.
how do you form that trust? It has to be based on real data.
Yes.
Um, Tell me how the
Yeah.
team supports that, how that
So we
interaction
we
takes
have a
place.
team of analysts that audit the practices.
Okay.
And they audit and present the data if there are any discrepancies, and they identify why that is. So that maybe they're putting it in the wrong field in the electronic health record, so they're not getting credit. So then we go over that and show them so they know what they need to do. So when we electronically pull the data, it's in the right field to get credit. And we give them credit even if it's in the wrong field. We then enter it ourselves if we find
Good.
this to support them.
Part of the trust equation.
Yeah.
All right, tell me more about what are the quality elements that the physicians say, those are the right ones.
Mm-hmm. Mm-hmm.
You guys are real. We're not gaming this.
Mm-hmm.
What are the most important quality indicators here?
Okay. First of all, these quality metrics are for all patients, all payers, not just Medicare. And that's
Mhm.
by design because Medicare wants equitable care for all patients. So
Right.
and they totally agree. When we started the program, it was just for Medicare patients. And they asked me, why isn't it for all patients? Because they're absolutely right. So now it's for all patients. And there are two key focus areas. One is chronic condition management for hypertension and diabetes,
Yep.
managing that population.
Right.
And the next is screenings, depression screening for the entire population and follow up if needed, and age appropriate cancer screenings. Those are the core
Yep.
focus areas right now.
Are the physicians pressing for more and better indicators, or are those good enough for them right now?
No, those are nationally known HEDIS measures. So they're
Right.
not new to them. They've been doing these since medical school. There's nothing, and what I try to do is support them. Like for hypertension management, giving them cuffs to give out to patients so they can do home blood pressures. And I try to support so they can be successful. Diabetes, we have virtual endocrinology consults so that our endocrinologist can make recommendations to the PCP without any expense or without the patient going to another appointment. So we try to do what we can to support them being successful.
One of the things you had mentioned before is the real-time analytics. I guess that goes back to the dashboard. Can they literally tune in at any time and see where they are on the spectrum?
Absolutely. Anytime.
So
This
what,
is like updated daily.
what does it take to put together a dashboard that's credible and real and in real time?
Thankfully, we're on Epic, and Epic
Mhm.
had created dashboards that we could utilize, customize for our purposes. So we worked with Epic, the Epic team, to build those in 2017. And we work in 13 different EHRs because we work with private physicians as well as employed. And our private physicians don't all have dashboards, which is why we had to develop this population health advisor team to bring them their data. And we have a partner for data aggregation that can aggregate in all these different EHRs and customize. We work with a company that can do that because it's highly technical so that we can give every physician their dashboard monthly.
What's the through point of working with different EHRs? How does one pull that off?
Our analyst team. Our
Mhm.
analyst team. We have people designated to understand all these different EHRs, to be able to audit in them, to be able to make sure the data is accurate and the aggregator of data. Our analyst team. That's really their core function, is to work in those EHRs.
Okay, getting back to professional pride, the other thing you mentioned is medical ethics, which could be a touchy subject for some. What does this mean in real life with physicians? What does medical ethics mean?
I think it means like when you are taking your professional pledge as a physician, as a medical student, when you graduate, it actually means that patients come first and that everything you do is in the best interest of a patient. in the best interest of a patient. That is really, in the simplest form, what that means. And in a program like this, with the focus on improving quality of care for patients, and that includes preventing readmissions, preventing avoidable admissions, preventing ED utilization, that includes that. That's all quality. Those last things I mentioned that have to do with healthcare utilization, that's where the dollars are coming from. Because that's, all those patients that aren't admitted is a savings compared to the previous year.
I mean, one can stretch medical ethics to say that defects, for instance,
Mm-hmm.
everybody should be focusing on defects, whether it be, waste or inappropriateness, whatever. If a defect is spotted, does a physician understand that has an ethical component? We messed up, we missed something.
Oh, yes, yes. I really think we have developed a culture where we can be completely transparent because usually it's not about people, it's about process.
Yeah.
It's usually about process. So if there's a defect, then how did this happen? It's no one's fault. What's important is that we're transparent in reporting it so that we can look at our process and say, how did this happen? We need to build a better process.
I think that's part of medical ethics.
Yeah.
We sure. We don't usually look at beyond the financial aspect, but yeah, there's obviously an ethical component.
And the other piece of this, when you achieve this return on investment, is investing back into resources for patients. That's a big, big piece of this. There is obviously a financial, but that's small compared to the investment into patient resources for community partnerships, benefits at no cost to patients, as well as staff, nursing, pharmacists, case managers at the bedside, all these people, population health advisors to make this work.
All right, so you mentioned one of the goals is population health improvement. You have a
Mhm.
double bottom line. What is your double bottom line, and what's the bridge from the clinical side to the community side?
Okay. Since we're focused on improving quality for all patients, all payers, this is far beyond the Medicare population.
Right.
So it's millions and millions of patients that we're now providing data on for all of almost 400 primary care providers. So I feel that is improving a huge population in terms of quality. But we also work with community partnerships for subsets of the population that have special needs. Like we have subsets that are going on dialysis. So we have a partnership with dialysis centers with shared goals to prevent missed dialysis, to prevent readmissions. We have shared partnerships with community partners that take care of cognitive impairment and the caregiver of those patients because these are subsets that need special expertise. So I think while we're improving a population at whole, we're also focused on community partnerships to better take care together, shared goals for subsets of our population.
So if I understand this, my interpretation would be that you have a lot of clinical indicators that you're looking at.
Mm-hmm.
The better the indicators are, the better the population is going to be, which is a little bit different than targeted investment in social infrastructure per se, which is more community-based than clinical-based. Is there an interface between those two points of view or those two programmatic parts?
Yes, because the non-clinical factors can completely influence outcomes. So
Right.
we have community partnerships, for instance, with the Houston Food Bank, Meals on Wheels, so that when we discharge patients, we can make sure them and their families have resources. So we have community partnerships to help take care of those needs. We also have our social workers have community partnerships for even housing with real estate agents and things like that, because those factors, if you can't afford your medications or if you can't get to your appointment, it doesn't matter that you have a prescription for a medication. Right.
Sure.
So we have to really address those up front. And our clinical pharmacists are really experts on cost of medications and resources available.
So you mentioned social workers, a critical cog. Are you working with community health workers?
That's a great, great, great. We call our community health workers more care coordinators. We probably have a different word for them.
Are these folks from the community with lived experience, or are they clinicians who have graduated to a broader
These are
school?
non-clinical people that work in the ACO, actually.
Okay.
So they're not like your traditional community health workers that are coming from the community. They are not in that subset. But I think that's an excellent resource. I've seen a lot of great programs that utilize that. And if
Yeah.
we had a need for a particular population, let's say in a certain zip code or something, I think that would be the solution.
Are you looking towards block level data as you move forward as opposed to zip code data? For instance, if you have that level of focus and that granularity, you can do a whole lot more than if you're looking at census tracts. Is that part of the agenda going forward?
We are always looking, what our major source of data is claims data combined with clinical
Mhm.
data, because that's our healthcare utilization with healthcare data. That's our platform. We combine that, always looking for opportunities where we're not doing well compared to other ACOs possibly, or we could do better. We're always doing analysis and comparisons of ourselves in multiple levels, looking for opportunities. Like one year, we discovered we were using ambulances so much, and we realized that these patients didn't know the benefit they had and how to call that benefit and all the resources. So that we look at the data to address what is it we're not doing well and why is that? What is the need here for these patients?
One of the trends, at least in different parts of the country, is as they become more aware of what drives health, what drives disease, the social determinants of health, you begin to invest in those communities directly around your catchment area.
Mhm.
Is that part of your focus? And are the hospitals in Greater Houston, is there any move towards cooperation of how to target certain parts of the geography that have more unmet social needs than others? And how do we singly or jointly begin to invest in those communities?
Houston Methodist has a community benefits department, and each year they give millions in grants to federally qualified health centers focused on primary care and behavioral health. And I used to be one of the reviewer for these grants actually on that committee, and where we would go in and look for community partners to reward dollars to support this effort, to support our patients at Houston Methodist. And that still goes on today. Millions of dollars are distributed to, with a focus on behavioral health and primary care within the greater Houston area. And we utilize those resources in our program and all programs at Houston Methodist. They're a good partner of community benefits.
So, some other locale, they heard the podcast, not quite sure what to do. How do you start this? How do you gain this? How do you make the impact that you're making elsewhere? What's your two or three things? Here's what you got to do first, second, and third.
Okay. Thank you. First, you have to say, are you ready? Do you have a primary care network? Do you have staff? And you have to realize you're going to have to invest your health system, or it will have to invest in the first 3 years probably to break even, like any startup. You have to realize that's going to be essential. So you need support from the very top. After you broke even, then you have to make sure that your physicians are engaged and you have great data analysis. Because one of the key things here are physician engagement, data analysis to know where you are, where you're going, and where are the opportunities, and patience. Patience. We've been doing this since 2017, and our best results were in 2024. Not to say, I mean, the first year we brought back 1 million, but that's a big difference from 50 million because you grow each year, you learn each year, and you have to have patience and you have to invest in the future, knowing that the first 3 years aren't going to be easy.
Yeah. So what gives you optimism going forward?
That I know I'm improving care for patients in a vulnerable population as they get older. 10,000 people a day are turning 65. And it gives me great joy that I'm able to work with I call my dream team and all these incredible primary care physicians to know we are making a difference. We are making a difference. There's nothing better than that.
Julie Andrini, Thank you very much. This is terrific, and I hope people can understand what you bring to this in terms of values and being truly patient driven. It's values driven. And I'm very optimistic. Thank you very much for joining us today.
Thank you so much for this opportunity. It's so enjoyable. Really appreciate it.
Thank you again.